It is gonna be a long trip.
Yes, sir. The problem that I slept well, and don't know what to do to make use of this time. Yes, I remembered. Please, sir, I tried many times to understand, or even memorize, Sphingolipidosis, but I was not able to do it.
Don't worry. I will make it like a piece of cake for you. You know, sphingolipids are complex membrane lipids. These phospholipids can be divided into three main groups: ganglioside, cerebrosides, and sphingomyelins. Normally, lysosomal hydrolases enzymes break these molecules down into smaller different products. Deficiency of any of these enzymes will lead to accumulation of the corresponding substrate, and that will result in progressive intracellular storage of this particular lipid substrate. I would like you to know some basics before starting. That will make your life much easier. There are 7 main diseases that belong to sphingolipidosis. All of them are autosomal recessive except Fabry disease. Second thing, out of the 7 diseases, there will be 4 diseases that we will compare them from 4 aspects. Those diseases are GM1 gangliosidosis, GM2 gangliosidosis that include Tay-Sachs disease and Infantile disease. Last 2 diseases are Gaucher disease and Niemann-Pick's disease. The 4 aspects are psychomotor deterioration, neurological manifestations, hepatosplenomegaly, and presence or absence of cherry red spot.
Sorry, doctor. What do you mean by cherry red spot?
The cherry red spot is characterized by an opaque ring. This ring is sphingolipid-laden retinal ganglion cells, encircling the normal red fovea. There are other 2 diseases that share almost pure neurological leukodystrophic manifestations. These diseases are Krabbe and metatraumatic leukodystrophy. The 7th and last disease have a unique clinical picture that can never be missed, which is Fabry disease. We'll start by discussing and comparing GM1 and GM2 gangliosidosis. Generally speaking, both GM1 and GM2 gangliosidosis are autosomal recessive, as I mentioned. GM1 occur due to defect in chromosome 3p22.3. GM2 gangliosidosis is a group of diseases. The main 2 diseases are Tay-Sachs and Infantile disease. GM2 gangliosidosis occur due to defect in chromosome 15q23 in case of Tay-Sachs disease, and 5q13 in case of Infantile disease. For easy memory, remember this: 3 GM1 times 5 Infantile equals 15 Tay-Sachs. GM1 gangliosidosis, present due to defect in beta-galactosidase that leads to accumulation of the ganglioside within the cell. While GM2 disease present due to defect in hexosaminidase A deficiency in case of Tay-Sachs disease, and hexosaminidase A and B in case of Infantile disease. I need to mention one important note: gangliosides are glycosphingolipids, are normal constituents of the neuronal and synaptic membranes. So any defect, expect neurological manifestations. Infantile GM1 gangliosidosis presents at birth or during the neonatal period, with psychomotor retardation in the form of global developmental delay, and as sequence of that, anorexia, poor sucking, and inadequate weight gain. Tay-Sachs disease has a similar manifestation but starts at 1 year of age. On the other hand, despite Infantile being so similar to Tay-Sachs disease, however, it is presented milder, and around 6 months earlier. So, to recap that, GM1 psychomotor retardation starts at or just after birth, Infantile starts by 6 months of age, and Tay-Sachs by 1 year.
That is why I always remember Tay-Sachs disease by this sentence. Tay gets high hex, after being number 1. Hex, for hexoseminitas, after being number 1, as psychomotor retardation occur by 1 year. But when a moment, why hi? I will tell you in 1 minute.
Neurologically, both GM1 and GM2 will share the 3S manifestations of spastic quadriplegia, CLS, that is blindness and generalized seizures. In addition, GM1 will be presented by deafness, apathy and decerebrate rigidity. On the other hand, Tay-Sachs will be really high head, that is macrocephaly, and high ears, that is hyperachiasis. Hyperachiasis will be presented in the form of marked startle reaction to noise that is evident soon after birth. In GM1, hepatosplenomegaly is present early in the course as a result of accumulation of foamy histiocytes. A cherry red spot is visualized in approximately 50% of cases. In case of GM2, see this table and you will know. There are some more important infos I would like to mention about GM1 gangliosidosis. The facial features are coarse, the forehead is prominent, the nasal bridge is depressed, the tongue is large, macroglossia, and the gums are hypertrophied. Kyphoscoliosis is evident because of anterior beaking of the vertebral bodies. Children rarely survive beyond age 2-3 year, and death may be from aspiration pneumonia. Juvenile GM1 gangliosidosis is a delayed onset beginning about 1 year of age. The initial symptoms consist of incoordination, weakness, ataxia, and regression of language. Thereafter, convulsions, spasticity, decerebrate rigidity, and blindness are the major findings. Unlike the infantile type, this type is not usually marked by coarse facial features and hepatosplenomegaly. Radiographic examination of the lumbar vertebrae may show minor beaking. Children rarely survive beyond 10 years of age. In case of Sandhoff, doll-like facies are present in most patients. Death within 2 to 4 years. Death is usually associated with aspiration or bronchopneumonia.